He's one of the best experts on proteasome inhibitors with a very nice recent paper focusing on the toxicity of new agents together with Heinz Ludwig. So, Michel, please.
Thank you very much, Philippe, for the introduction. Thank you, Professor Multi and Nagler, for the invitation. So I'm very honored to be here, and good morning to all of you. It's always a challenge to be the next speaker following Xavier, so the stage has been heated up by him, so that's very good. The topic of my talk is the use of the proteasome inhibitors in relapsed refractory myeloma. And I have only 2 or 3 introductory slides. For those of you not so familiar with the mechanism of action, we have heard a lot of interesting data about IMiDs, and we know to some extent how they work. But with the proteasome inhibitors, from the beginning on, I think we could much better put our finger on their mode of action. And just to remind you that proteasomes, they are multicatalytic enzymatic complexes, so they're present in every cell. And so they consist of regulatory caps and catalytic central units, enzymatic units that will chop the proteins into peptides. And this is done because the proteins that need to be degraded by the proteasome, they have a tag which is usually a tail of ubiquitin residues. Just as like IMiDs and many other compounds, proteasome inhibitors, they have a very pleiotropic mode of action. So they will directly target the myeloma cells, which are much more sensitive to proteasome inhibitor than many other cells, and especially than healthy cells. And the NF-kappa B pathway is central in this mode of action. But in addition to that, there will be also several other mechanisms why myeloma cells will be pushed toward apoptosis. There are influences on cell adhesion molecules and on the microenvironment. Now, currently, we are fortunate because there are several proteasome inhibitors developed, and most of them are available in multiple myeloma. Just to remind you, we have several classes: the boronic acids, the epoxy ketones, selenospore inhibitors, and bortezomib, ixazomib. They are boronic acid derivatives, and they primarily target the chymotrypsin part of the catalytic unit. And as you know, their mode of administration, their frequency of dosing is different. And then in addition to that, we have carfilzomib, which is an epoxy ketone, just as the oral compound oprozomib. They target chymotrypsin, and they are irreversible inhibitors of the proteasome. And then finally, there have been also some more recent data on the use of marizomib, which is a pan-proteasomal inhibitor, also irreversible inhibitor, and this could be an interesting drug for central nervous system involvement. Now, just to remind you the history of the approval of the proteasome inhibitors, and we have to go back to 2003 for the first approval of bortezomib, and later on it was second line 2005 in the US, 2008 at both sides of the Atlantic upfront for in Europe non-transplant eligible patients, and then only a couple of years ago it was approved by EMA for first-line treatment in combination with dexamethasone or dexamethasone plus thalidomide. For carfilzomib, it's more a recent approval, so it started in 2012 in the US, but at that time the dose was only 27 milligrams per square meter, and then in 2015 and 2016 KRD and respectively KD were approved in Europe as second-line treatment and beyond. And then finally, ixazomib 2015 in the US in the combination with RD, and the same combination was given the green light from the European Medicine Agency in last December. Now, just to give you a brief update on some new data with bortezomib in the relapsed refractory setting. And Most of you will be familiar with this slide because this is the design of the CASTOR study that was published last year in New England Journal of Medicine. And the design of this study was for patients from second line on to randomize them between standard Bortezomib-dexamethasone regimen compared to the same regimen plus the administration of the anti-CD38 monoclonal antibody Daratumumab, with PFS as the primary endpoint. Now, this is the core or the critical finding of the study, the primary endpoint progression-free survival for DVD versus VD, with at moment of publication a median follow-up which was around half a year. But even here you can see that the PFS in the DVD arm was very significantly longer compared to VD, with an hazard ratio for PFS of 0.39. Now, building further on this concept, there have been many sub-analyses done, and some of these have been presented at the IMW workshop in New Delhi, but they are not yet published as full papers. However, let's have a look at some of these sub-analyses. You have heard from previous speakers that MRD has now become a realistic target in relapsed myeloma. And also in this study, MRD has been studied by next-generation sequencing with several levels of sensitivity ranging from 10-4 to 10-6. But the take-home message here is that MRD negativity can be achieved in 3 to 4 times more patients in the DVD arm compared to VD. And then, of course, the question is, what does this mean in terms of PFS? And as you can see on the right side of this slide, that patients who were MRD negative, irrespective of the fact with which treatment this was obtained, their PFS was here nearly a flat line with a median follow-up already exceeding 1 year. And also importantly, that even if patients were still MRD positive, which is of course still the major part of the patients, their outcome was much better with DVD compared to VD. And the second group of unmet medical need patients are those with, as we know, high-risk cytogenetics defined as translocation 414, del17p, and translocation 1460. But interestingly, if we focus on the patients with high-risk cytogenetics, we see that their hazard ratio for progression-free survival is 0.50 with DVD compared to VD, so in favor of DVD. So this makes DVD a very attractive regimen for treatment of high-risk cytogenetic patients at relapse. By contrast, you see here that for the VD arms, VD standard risk and high risk, the median PFS is superimposable. And then, of course, you can question, well, what if patients have already been pre-exposed to bortezomib? Does it make sense to give retreatment in the area of other treatment possibilities? And this slide tries to answer this question. And in the CASTOR study, around 2/3 of the patients had been pre-exposed to bortezomib. Patients refractory to bortezomib, they were of course excluded of the study because a patient had 1 chance out of 2 to be randomized in the VD arm. But as you can see here, for patients in the VD arm, those who were pre-treated or not pre-treated, their median PFS again is between 6 and 9 months. However, in the DVD arm, patients who had prior exposure to bortezomib, as you can see here with a median follow-up of 13 months, their median PFS was not yet reached. Okay, a second interesting drug that might in the future be an option to combine with bortezomib or other agents is the XPO1 inhibitor selinexor. So selinexor is an oral drug that inhibits nuclear exporting protein 1, and as a consequence it retains some anti-apoptotic molecules in the nucleus. And this is a complex slide, but it shows you some data from phase 1, phase 2 study where selinexor has been combined with dexamethasone. This comes from the STORM study in quadruple and pentarefractory patients, but also the combination with dexamethasone plus bortezomib or carfilzomib or pomalidomide. And interestingly, if you focus on this part of the slide, you see that the combination of selinexor, bortezomib, dexamethasone has an impressive overall response rate of 77% and a clinical benefit rate exceeding 90%. And in this study, or for the moment, it has been decided that the optimal regimen is selinexor once weekly, 100 milligrams, orally in combination with bortezomib once weekly. And this will be also the dose for the phase 3 study, which is the Boston study. In terms of treatment-related adverse events, if I'm right, there were some concerns about anorexia and nausea in the initial phase 1-2 dose-finding studies. But here the recommended phase 2 dosing for SVD, you see that there is no grade 3 or 4 anorexia or nausea. There is, with this combination, some hematological toxicity in terms of thrombocytopenia, anemia, and neutropenia, but as you can see, this is not so high according to other regimens, and this is manageable. Now, the second part of my talk is what's new about carfilzomib. And then let's go back to the pivotal studies. So you see here the design of the well-known Endeavour study comparing KD and Vd with the carfilzomib at 56 milligrams per square meter. And you have seen this slide at many, many occasions. So this is the median PFS, which was twice as high in the KD arm compared to the Vd arm. Now, there has been an update shown at IMW on the overall survival from this Endeavour study with a median follow-up of 3 years. And as you can see here, the median overall survival in the KD arm was significantly longer compared to the Vd arm, which an hazard ratio of 0.80 and with a net increase in overall survival of a bit more than half a year. What about the ASPIRE study? So ASPIRE compared KRD with RD. This comes from the original publication from Dr. Stewart. You have seen this at many occasions. KRD, median PFS 26 months compared to 17 months with the RD combination. So the update on this progression-free survival with a median follow-up also of a little bit more than 3 years. So the conclusion was that still KRD resulted in improvement in PFS, time to progression and time to next treatment compared with RD. And in addition to that, there were also no new safety signals with prolonged use of this regimen or also with prolonged follow-up. Now, coming back to the high-risk cytogenetics, you have seen this slide in the previous presentation from Xavier, but importantly, so KRD is also an attractive regimen for patients with high-risk cytogenetics, although the median PFS is a little bit shorter, as expected in this subgroup compared to patients with standard risk cytogenetics. Now, just briefly touching upon adverse event management, as you know, one of the concerns with carfilzomib is the cardiovascular toxicity in a limited subgroup of patients. By contrast, there is no peripheral neuropathy of any clinical relevance with carfilzomib. Excuse me. Now, although this is a study from first line, I just want to show it because it looked more in detail at cardiovascular issues. And this is a study that was primarily conducted in Italy, but you see here, although the numbers are not so high, you see different dosing of carfilzomib in combination with cyclophosphamide and dexamethasone. But the median age of the patients was 72 years, and 1/3 of the patients had one or more cardiovascular comorbidities at baseline. And the conclusion from this study that there was a higher rate of carfilzomib dose reduction and discontinuation in patients with one or more cardiovascular adverse events. And even that resulted in some increased mortality. But I don't have the precise details what were the causes of that, but anyway, the conclusion from this paper was that especially in very elderly patients, there is an increased risk of cardiovascular events with carfilzomib. And this is just a kind of a proposal, and without going in too many details, I think we should really keep a close eye on the cardiovascular status of patients before we start treatment with carfilzomib and also during the treatment. So simple measures like blood pressure control before the treatment, following the treatment, just to ask eventually people who have already an elevated blood pressure to measure it at home to treat it appropriately. And by doing that, we can, in some patients, prevent more serious toxicities or complications. And finally, a few words about the oral proteasome inhibitor ixazomib. So you are very well aware of the publication by Philippe Moreau, and this comes from the subgroup analysis, where it's really very interesting to see that although also the number is not so high, but that patients with high-risk cytogenetics, they might really benefit from this combination, or maybe this combination could abrogate the high-risk or the inferior PFS associated with high-risk cytogenetics. And the same is true, and even more impressively, for patients with more prior lines of treatment. So we do know that at the dosing of 4 milligrams ixazomib on days 1, 8, and 15, there has been no safety signal regarding hypertension or cardiac failure. However, in the phase 3 study, there was a slight increase in thrombocytopenia, and some patients also developed a rash. Now, at IMW, there were 2 interesting phase 2 studies building further on the ixazomib-dex backbone. One study was from Dr. Kumar, combining cyclophosphamide with this doublet with cyclo 300 milligrams square meter on days 1, 8, 15. And the second study is from Dr. Ludwig, combining or adding thalidomide to dexamethasone. So here you see the regimens. Importantly, we just discussed thalidomide in this regimen. After 8 cycles of kind of induction, the thalidomide was stopped, if I remember well. So these were patients who had relapsed myeloma, and you see the PR rates or better are pretty comparable, occurring in around 50% of the patients. And importantly, with these combinations, there were no additional safety signals. So to conclude, it's beyond doubt that in relapsed myeloma, proteasome inhibitors remain an important backbone. And even at the era of second-generation proteasome inhibitors, Bortezomib-based regimens still play an important role in the management of relapsed myeloma. And of course, this is depending upon frontline treatment, but in the near future, the combination of daratumumab, bortezomib-dex, dexamethasone will be very interesting because it has an impressive superiority compared to Vd, and not in selected subgroups, but let's say in nearly every subgroup. Of course, with the exception of patients who are bortezomib refractory, who have not been tested in the study, and there is of course concern if there were toxicities or serious toxicities from prior exposure to bortezomib, or the patient has pre-existing peripheral neuropathy. And of course, according to availability, and we just heard it, and we have to realize it, that in many countries, in many parts of the world, the availability of all these latest drugs is very limited. And then we have to keep in mind that some other combinations with bortezomib are still very attractive and, most importantly, also very effective for myeloma patients. In many European countries and in the US, carfilzomib-based regimens are the standard of care of the management of relapsed myeloma. But this is a very active combination, but we have to realize that the cardiovascular toxicities will preclude its use in some subgroup of patients, and also the administration regimen of carfilzomib is complex and it puts an enormous burden on daycare clinics. Then, of course, there are some controversies and challenges. And all these more highly effective treatment regimens, they create more complexity in the therapeutic decision making. To give you an example, if a patient will relapse, would you go for KRD, would you go for DVD, or would you go for another regimen? This is depending on many factors, patient-related factors, disease-related factors, previous treatments, and we really would like to have some kind of calculators helping us in making these complex decisions. Although I have to admit, and I hope you will agree with me, that most of the time it will be a physician-based decision, but it's always helpful to have some technical backup support. Each major therapeutic breakthrough in frontline will have its impact on the treatment in relapsed myeloma. So once the very active triplets will go to the frontline treatment, of course this will reflect how we will have to deal with relapsed myeloma. And then, as already indicated, there will become more and more differences between treatment availability in the different countries because of the very high cost of these novel agent-based triplets. And finally, as indicated, we really need to incorporate all factors we know, all factors that are important to make an optimal treatment decision. And with this, I would like to close and thank you for your attention.